Hello, everyone, and welcome to this week's edition of MOJO Rising, How to Make Cancer Suck Less. And this episode is near and dear to my heart. And let me explain a little bit why. As you guys know, I am a stage 4 cancer survivor. But as soon as someone said the words, "you have cancer," I immediately went into panic mode and wanted nothing more than this cancer to be taken from my body. So today's episode is teaching you why you likely have time, why you likely can take time to collect data and build your body up, because it's really not that urgent in most cases. But I know my perspective alone won't help you understand this. So I've invited my two most favorite cancer specialists in Dr. Chad Levitt, who is a 20-year veteran oncologist. Chad, you want to say hey real quick?
Hey, Chad Levitt here, radiation oncology trained, cancer consultant and physician here in Atlanta, Georgia.
Awesome. And of course, most of you, our listeners, know the great Oscar Sierra. So Oscar, do you want to share a little bit about your background for anyone who's just joining for the first time?
Yeah, I am not a physician or a medical doctor like Dr. Levitt is here. I help people navigate through their journey of conventional medicine and traditional medicine and try to help them dial in the best of both worlds and timing. And so I'm glad that we're not so much, focusing on, astragalus or vitamin C or IV vitamin C or IV this or that, but we're talking about the timing element, which is probably the most missed thing in cancer land. So I'm glad that we're dedicating a whole show to this.
I think it's so important as well. And so, just to share a little bit about my story, as most of you guys know, the only reason I was diagnosed was because I had low iron. Went to the gastro to have my colonoscopy done, and he woke me up and said, "I think you have cancer." And I said, "Okay, talk to me like I'm your sister, not like I'm your patient. And do I have cancer? Do I not have cancer?" And he said, "You had a tumor so large that I couldn't get the infant-sized camera around." And my immediate answer was, "How long do you think that's been growing?" Actually, that's not true. I was like, "I'm not a 7-year-old man. How is that possible?" And then I said, "How long do you think that tumor has been growing?" And he said, "Probably 10 years. And it hit me right then. This has been growing inside of me a long time. I've got a little bit of time to figure out what my plan is. But I don't think most people would ask that question right away and have that asked and take away that takeaway. So I thought it would be really important for us to discuss this. So, Dr. Levitt, in your professional opinion, most people, I'm guessing, would come to you thinking, "We need to start now. We need to start now." But what's the reality? Is most cancer urgent where you don't have time to stop, drop, and roll and really think about things? Or do you have time to really think about your strategy?
Sure, great question. And I guess I should add a little bit about my background is that I do come from a liberal arts background where I studied a lot of existential philosophy and have degrees in that, and really focused on the human condition, which drew me to oncology in the first place, to kind of help patients when they're dealing with something a little bit more significant than like the sniffles, earaches, and sore throats. But the reason I bring that up is because I think it's so relevant to how to deal with the emotion and the traumatic experience of a new cancer diagnosis, or even just hearing that cancer word as it applies to you. Because culturally, it has a stigma, it has an emotional aspect to it, and it can greatly cloud your decision-making process that you might otherwise apply in a really reliable way to other aspects of your life. So it is a mystifying disease topic to deal with. And so your point is exactly right, is the reality when you are notified about a cancer diagnosis or a suspicion of a cancer diagnosis is that nothing's really different that day from the day before, other than your awareness that this is something that's going on, because it was going on the day before, it was going on the weeks and months before, and it may have been going on a couple of years before or not, but you don't know. Yet culturally, the anxiety, the emotions, the the sort of tunnel vision that starts to sink in when you're sitting in that chair and someone's giving you this kind of surreal information that feels out of body almost. And you feel like your sense of control and all your best laid plans are just melting away, and nothing else has any significance other than this diagnosis that has to be dealt with right now. Is it clouds your ability to deal with it maybe in the same way that you can depend on in other aspects of your life. And so the majority of the time, while your gut reaction and of course your support systems too, who also are bewildered and anxious by that piece of information, want to fix the problem. Our bodies, our brains, our culture, our society is set up to try to define things in ways where there's patterns that we can decipher or decode and then fix or feel like we're fixing, which is really just a way that we regain a sense of calm and peace that goes with feeling as if we control something, when in reality, I think a lot of us realize and know from living a certain number of decades in life that there's very little in life that we actually control other than really our response to what happens around us. And so the urgency, the emergency that comes with a new cancer diagnosis is often fictional. It's not something that demands first response as soon as possible. It demands attention, it demands processing, it demands an education, and it demands a personalization of how you want to approach it and strategize it. And those things need to be started somewhat urgently, but jumping to dramatic, invasive, potentially toxic treatments that possibly expose you to taking shortcuts or burning bridges of information or data collection or making good informed decisions, can fall victim to is not in most situations the reality. There are situations where clinically something is found at such a state where it is an emergency, but most of the time, when you give that diagnosis or that information to a patient or receive it as a patient, it's not as much of a surprise. By the time something gets to a point of you have to make an urgent decision right now or by tomorrow, you usually had an idea something was going on for quite a while. And our bodies, that brings up a whole other topic of our ability to suppress things and focus on other things that are more attractive to spend our time, energy, and attention on. But losing weight unintentionally over many months that might have preceded the time where you actually had pain and needed to go get seen by a doctor, and they gave you some really bad news that resulted in an emergency type of situation where they're saying, well, we need to get you to the hospital, we need to give you a blood transfusion, things like that, or we need to take care of this right now at all costs. It's very rare, and it usually is not without a heads up type of experience that no fault of anybody's, but maybe there was a consciousness of. So urgencies are in addressing things and coming up with a game plan, but not jumping to treatment decisions out of the gates.
I think you just brought up something that I is absolutely one of my takeaways of cancer. And that was that the only thing I could control is my energy, how I spent it and where I invested it. And I did have the emotional urgent breakdown. It was not a physical urgency. It was emotional, where I truly went through that crisis of I wanted this cancer out of me so fast. I want it out now, cut it out, whatever you need to do whatever you need to like, take it. I was willing to do whatever it took to get this cancer out of me. And that was exactly the wrong thing, Now that I understand my journey, that emotional craziness that I was creating was chaos and it actually didn't serve me at all. So this purpose of this podcast is to help you slow down. Let's help you understand when it's urgent, when it's not urgent, when you can take some time so that you get a little bit of rest as you're trying to build your strategy. Oscar, when you think about this and you've seen a lot of different patients across different cancers, when you look at this, if you were to give a percentage of patients, how many patients were actually literally urgent versus more of that emotional urgency that we feel?
You mean biomedically urgent?
Yes.
Less than 5%. I mean, yeah, way less than 5%. I mean, occasionally some hematological cancers, you get to do something within 3 weeks or something, but those are rare, few and far between, and most of it, like Dr. Levitt said, like if they are, like in your case, like you had an actual obstruction, that was a urgent plumbing problem, which was kind of a mechanical thing. It wasn't really the procedure that was kind of the first off the bat wasn't really treating the cancer. It was just treating your plumbing, right? And obstruction, my mom went through that, and that was semi-urgent, but even then not as urgent as, they wanted to do surgery on my mom the day of because of an intestinal obstruction. I said, whoa, her vitals are fine. She's stable. She just needs to poop. Yeah. And you're going to do surgery today? Yeah. Well, can you give us a few days to poop? Yeah, sure. We can do that. That's fine. So we gave her some herbs. She pooped and we walked out of there. And, that was over 10 years ago, and no surgery. It was going to be full abdominal open surgery. And there was no real emergency. Even that, quote unquote emergency wasn't like she was shot or stabbed or something. Like those are emergencies. So, emergency is all relative, and it's important to note, yes, absolutely. There is a knee-jerk reaction that is psychosocial emotional. It is not a true biological emergency. So let's call a spade, and let's not fuel the psychological emergencies, because those actually biochemically do create inflammation, which then feeds cancer. So there, interleukin-1 is a real cytokine that is produced when people go into fight or flight mode, which is not bad because, when there are bears, you got to run fast and you need adrenaline to, make you run a little bit faster than your normal white lady, right? But when there's not an actual bear, that interleukin-1 cytokine pathway storm is actually going to do exactly the opposite of which one's going to make the cancer go faster. So, it is normal to freak out, and it's fascinating. It's kind of a side note off of the when topic, but the what topic, as Dr. Levitt said, cancer has a stigma, right? Like how many people are diagnosed with cardiovascular disease every day, and people really don't give a crap about that, although they're way more likely to die of a heart attack or a stroke. But they're probably going to eat bacon sometime in the next week or two, and they don't care. It's way more deadly. But it's fascinating how you say cancer, especially something like breast cancer or prostate cancer, which are really the least of medical emergencies. They're common, but they're generally not deadly, and not deadly anytime really soon. And statistically speaking, it's not going to be the thing that takes out a, over 50-year-old man or woman. It's going to be cardiovascular disease. Yet they still freak out as if, there is an actual bear. Why? I don't know. It's a phenomenon that is just, if aliens were watching us from afar, they would probably be cracking up, being like, those humans are just weird. Anyway, I don't know. I don't have an answer for that. I don't know what it means, but I also don't want to say it's entirely a negative thing, because that stigma is a motivating factor. And I have seen, and my teacher, Donnie, can account for many, many cases. In fact, probably most prostate cancer cases where they had diabetes, they had heart disease, and they're still eating bacon and, sugar and Diet Coke and regular Coke and pancakes and wheat and all this stuff. And they're not really changing much. And then they get diagnosed with cancer, and oh my God, now they want to go gluten-free, and they want to, do the probiotics and the vitamins and start exercising and stuff. And that caused them to not die of the thing that they were going to definitely die of, which is the diabetes and heart disease. And the best thing that could have ever happened to their overall survival, which is the why, not the when or the what. Most people care because they just want to live longer for some weird reason. Mine is music, love, but that's the why, right? So, but for some weird reason, because of the stigma, they freak out, which we can kind of leverage. I hate leveraging fear. It's not what I want to leverage, but I will if I have to as a clinician. If nothing else is a motivating factor, right? Like we can leverage that fear and they'll actually use that freak out to change their diet, to change their lifestyle, to make amends with people in their life that they should apologize to or receive an apology from. And then they'll end up living a better quality of life and a longer quality of life because they freaked out about cancer. So I'm not going to say.
I'm going to just go ahead and say guilty, guilty right here. That was me. I had all sorts of diagnoses before I had cancer. All of a sudden it took one word of the C, and I did have bad cancer. So it wasn't an easy light cancer, but it was a decent cancer. And I was willing to change everything about my life and completely how I live it, what I do, what motivates me. So yes, I think you're right that it does have a way of waking you up that other words don't, because you just normalize the other words. But cancer is scary. But let's break down some of the things you just said. And I'm just going to pick one cancer, and that's breast cancer, knowing that impacts so many people. There are breast cancers that I think are faster growing or more aggressive, and breast cancers that are slower growing. So let's talk a little bit about, we a lot of times think breast cancer is one thing. I learned it is very not one thing. There's 1,000 different things that can break up a breast cancer, and the genomic type and the microsite stability and all these different things can impact breast cancer and how quickly it grows and how it replicates and all that fun stuff. So let's just take this one word breast that lots of people probably think is the same thing, but it's not, and break that down into why are some breast cancers fast growing and slow growing? How would you know?
I mean, I can tackle a little of that. Are you saying, well, I mean, extrapolate a little bit. I mean, there is no such thing as, an individual cancer. There is not a cancer that everything's related to. Cancer is a descriptive term that we apply to a lot of different types of diseases that behave on a cellular level in similar manners. But just as there's different breast cancers, that's very different than a prostate cancer or a bone cancer or a lung cancer or a colon cancer or a brain cancer. So it's I guess to answer your question, how do you know if it's a fast growing one or a slow growing one? It really depends upon which lens you're looking at it through. So there is a very, very rare and relatively small population of people who get breast cancer that clinically, from the time it develops to the time it's seen, to the time you get to the doctor, to the time that you treat it, it behaves rapidly. It changes quickly. It's noticeable. It spreads within weeks. And that's not the common form of cancer. That would be one way you would know. Like head and neck cancers, as an aside from breast, clinically grow rather quickly. So a classic story is that somebody was shaving, or a male was shaving, or somebody did a podcast or a TV interview, and they saw themselves and they said, wait a minute, what's that little lump on my neck that I've never noticed before? And by the time they went and looked at it further, it was bigger than when they saw it 2 days ago. It behaves clinically in a rapid manner. Now, fortunately, some of those fast-growing versions of some cancers, the head and neck ones, for instance, can also be destroyed rather quickly and effectively. So that's a good thing. But you can look at the clinical presentation, meaning what can I see from a physical exam with my eyes as I look at that patient? Are they losing weight very quickly? Are they all, what's happening to their body? Now, on a cellular level, it's a different story. You can look under the microscope at cells, and it's not like a normal cell is, let's say, pink, and a cancer cell is blue, and that overnight you develop blue cells or pink cells change to blue cells. It's not the way our bodies work. And that's not really what the major malfunction is when somebody develops what we call cancer or a cancerous disease. What's happening is just a little bit of a hiccup in the normal mechanisms that our unbelievably sophisticated bodies go through on a routine basis. So what I mean by that is that our bodies are not static at all. Not only are we growing throughout life, but we're constantly replacing old cells with new cells. Some cells, like our skin, we replace rather quickly. The old cells wear out, they get dry, they flake off, we wash them off, and then your skin develops new cells that come and replace them. And that's always happening. Other cells in our body you keep for decades or the majority of your life. We used to think neurons, like our brain cells and our spinal cord cells, this is what you got, that's it. If you injure them, they don't fix themselves. That's not true. They're just really slow in the way they grow and replace themselves and repair themselves. So what's happening is, in order to replace an old cell with a new cell, you obviously don't want to constantly be morphing and changing the way we look and the way our bodies are. Our body has some sort, the way we understand it today, has some sort of program. A lot of people would say, all right, our DNA is the source code. And it tells each of our cells, different types, our eyeball cell, our lung cell, our stomach cell, our skin cell, this is what you're supposed to do. This is what you're supposed to look like. So they actually have like a little expiration date where a cell is like a little creature that goes through a life cycle. People probably remember from high school or middle school biology, mitosis and meiosis and all that stuff about cell division. Well, that's what we're talking about. That's how that's how cells start. They go through a life cycle. They age, they do what they're supposed to do, they get old, they expire, and then at the end of their life, which is shorter than our lives as humans, they know they're supposed to clone themselves and replace themselves with new cells. And in order to do that, you want a perfect match. Well, that's a very complicated process to go through, as people remember. Mitosis was like 2 months of studying, and it was all these different things and steps. Well, that's all we understood, and it's way more complicated than what you get in middle school or even as a PhD biologist, but a cell biologist. There's all kinds of complex mechanisms going on, and it is not a perfect clone process. In fact, the majority of times that our old cells try to clone themselves, they don't make perfect copies. They make abnormal copies of themselves. And our body does an amazing job at doing safety checks, at checkpointing to say, wait a minute, that cell doesn't look just like the cell that I'm trying to replace. And you know what? We're going to get rid of it and we're going to try again. We're going to get a new cell. We want a perfect copy. So it's very hard to get those perfect copies. That process is going on all the time in our body. That is normal. Now, what's not normal is every so often you get a cell that makes an abnormal copy of itself, but for some reason, our body's safety checkpoints don't pick that abnormal cell up. In fact, that cell is wearing sort of like a cloak of invisibility and is sitting there knowing it gets abnormal, whether it has consciousness or not, but it knows it's abnormal, but it knows it's going to get under the radar and it's going to stick around and it's going to behave just like a normal cell, except now it's an abnormal copy of what should be a perfect copy, and it's going to clone itself as now you're going to have two abnormal copies. It basically forgot how to die. So instead of having an abnormal cell that gets destroyed and then a normal cell is made and replaces the old normal cell, now you've got two abnormal cells that don't know that they're supposed to replace themselves. All they know how to do is make more of themselves and clone themselves. So now instead of one cell replacing one cell, you've got two cells trying to replace one cell, and those cells try to replace themselves, and it starts this huge family tree. So you go from 2 cells to 4 cells, 4 cells to 8 cells, 8 cells, and it just doubles and doubles. And very quickly, it can get to hundreds of millions, if not billions of cells. And from a frame of reference, to Oscar's point about what's detectable by an MRI, a PET scan, an ultrasound, or a clinician, by the time a tumor gets to be 1 centimeter in diameter, a little spherical tumor or clump of cells, that's got about 1 billion cells in it, 1 times 10 to the 9th cells. And all you need for cancer to manifest or disease to manifest is one abnormal cell that's going to start replicating itself. So if you got 1 billion cells, that's a pretty, larger burden to get rid of. So that idea between a normal cell and a cancer cell is not a black and white, pink or blue differentiation. It's a spectrum of cells that develop abnormalities. And the more abnormalities or the more abnormal that cell gets, the more mutations it starts to generate. And ultimately, the uglier and the less normal those cells and its offspring start to become. So we can look at cells under microscopes, really high-powered microscopes or other types of tools, and really describe how ugly is this cell? How abnormal or how different from a normal cell does this look? Well, we know how normal cells behave. They don't do things very fast. They do what they're supposed to do in a pretty predictable way. The more abnormal a cell gets and looks, and certain aspects that we can look at specifically to describe it, the more aggressive and the faster it does start to reproduce. So to answer your question about how do we know what's a fast-growing disease or cancer versus a slow-growing, you can look at the clinical picture of how it's affecting a person's body, or you can look at the cellular level and describe, at least from what we know today, how abnormal those abnormal cells are. And really what cancer is across the board are cells that at one point were normal that developed these abnormalities that went under the radar of our body's checkpoint system. And your body, the problem is your body's immune system and your body's checkpoint system thinks those are normal cells. And so it leaves them alone. And as opposed to many other types of diseases, and then Oscar can probably speak differently and more to the ideas of the yin and the yang and the hot and the cold elements that go into our body's meridian balance and chi balance and all of those other ways to describe the disease versus immune system's constant human condition in balance from one another, is that these are cells that are behaving badly that your body doesn't pick up as abnormal. So it basically is handcuffed in its ability to fight those cells. And the longer that process persists or develops in our body, the more rapidly that disease can become known and can cause problems.
Thank you for that, Dr. Levitt. And
A lot of information.
it is, and it was really good. There's a couple things I just want to make sure our listeners heard. And the first thing I would say is you likely have cancer cells in your body every single day, but your immune system finds them. So it's not a problem. And so don't think that one thing happened or you did one thing that gave you cancer. No, your body constantly is malfunctioning. It just has a process that fixes the malfunction. What happens when you get cancer is when that process doesn't work for some reason or another. But I do believe that there are some things from hanging around you fellas that you can measure that measures how quickly a cell reproduces. Oscar, are there any diagnostics you use to measure how quickly a cell would reproduce or copy itself that could indicate how quickly it would grow?
Well, a conventional one is it's called the Ki-67. So that's kind of the proliferative index, or how fast, like Dr. Levitt said, 1 cell becomes 2, 2 becomes 4, 4 becomes 8, and so on and so forth. And and it's relative, right? So for breast cancer, who you mentioned, it's considered, fast if it's over like 25 or 30%, although relatively speaking, compared to like other cancers, of even like a 35 or 40% Ki-67 proliferative index, it is still not very aggressive. It's aggressive relative to most breast cancers. And, to kind of give you a sense of scale, I've worked with a breast cancer case that was like at 97% Ki-67, which is a very aggressive and strong. But even then, like, this is not like some alien, popping out of your abdomen, like in the movie with Sigourney Weaver, right? Like, you still have months to really kind of get your ducks in a row before you do conventional treatment. This is not, it's more urgent than your typical breast cancer, but it's not like aliens busting out of your abdomen. You have time to get your ducks in. Let's define what that means, because unfortunately, the standard of care really does treat it like a medical emergency. Like, oh, we got to get you right into chemo, surgery, or radiation, which is a horrible idea. I'm not saying that categorically surgery or radiation or chemo is a horrible idea. It's a horrible idea to not let and encourage people to take a long, slow, deep breath. I always tell my patients to do some LSD, long, slow, deep breathing, before they make any decisions. If it's taking our herbs and astragalus or yoga, or going into radiation, chemo, or surgery, they need to do LSD before all of these choices, and they need to be 100% on board of what they want to do. And is it what they want to do, or is it what the doctor wants to do, or your husband or wife or whatever? And do what you want to do. That's what this life is about. That's my why anyway. It's the freedom to do what I want to do, but that's not me. I'm not everyone. But if you're going to do a surgical intervention, you want to go into that with as low inflammation as you can possibly, because guaranteed outcome for that surgery is more inflammation. And it's going to be a lot more inflammation, because they're going to cut you. And as good as Dr. Levitt is as a surgeon, 100% of his patients walk out of surgery with, 20 times more inflammation than they walked into the surgery with, which is to be expected, because they're cut, and inflammation is part of the healing process, which I'm not saying inflammation is bad, but you want to go, because all solid tumors feed on inflammation to some extent, you want to go in to that surgical procedure with inflammatory rates that are very low. And you can measure CRP, SED rates, and other things, and you can get them down pretty darn quickly. I will give you an example. I had an ovarian cancer case. Lady had a CRP. She was just diagnosed, came to see me, thank God, before she started conventional treatment. But she would have started the next day had they had a room in the operating, room for her the next day. She probably would, like you. She's like, "Oh, cut this alien out of my body before it jumps out of my throat." And but they're like, "Okay, we got to do surgery soon." And soon for them was 2 weeks later, maybe 3 weeks. But she came in to see me, and she had exactly 2 weeks between my first appointment with her and her surgery. And I said, whoa, we got to get some baseline data. We got to be a data G. And her CRP was 110. CRP is C-reactive protein, an inflammatory marker. To give you a sense of scale, it should be below 1, ideally below 0.5. Hers was 110, okay? Whole lot of inflammation. To give you another sense of scale, months before that patient, had another patient with a CRP, C-reactive protein, of 127. She died the next week, okay? She'd already gone through the gamut of chemo, radiation surgery, and her family brought her to me. He's like, "Hey, what can you do with this?" And like, "Well, let me see what I can do." And a few days later, she was dead. And so that was the highest CRP I'd ever seen. And so when I saw, not months later, a CRP of 110, I said, "Whoa, whoa, this is a big deal." And it's not about to get better with surgery, is going to go up from there. So I maybe admittedly reacted in a big way, and I said, we got to throw everything, shake the chocks off the wagon, and throw everything at this. And we did a very, very robust protocol. That means she took a lot of stuff. And I checked her CRP again in exactly 10 days, and it went from 110 to 10 in 10 days. So I felt much better about going into surgery, because surgery would take it from, maybe 8 by the time she did surgery, or 5, probably back up to 50. But at least she didn't start at 150 and go to 200, right? So that's what I mean by is it biologically urgent, or do you have 10 freaking days, or you probably do. You know, even the most aggressive 97% Ki-67, we had, you know, couple months at least to really kind of get our ducks in a row before doing any major chemo, radiation, or surgery, and setting the stage for success. And what I frequently see is, you know, is people rush into stuff and they have a short-term myopic viewpoint, right? They're not thinking medium and long-term. I'll give you a recent example. A lady with kind of what we call a kind of garden variety ER positive breast cancer, which is totally not a medical emergency, you know, went into surgery pretty quickly, not urgently, but, you know, a couple months after she was diagnosed, and they had to go back in because they didn't get what's called clear margins, right? And that means more surgery, right? Because we didn't get everything the first time, so I got to go back in, open you up, and do the whole rigmarole and put you under, and, you know, more cutting, which means longer healing time and just more of a pain in the butt. You got to get some more dog sitters and someone to take you there and drive you back and all that stuff, right? So had she just listened to me before the surgery, I feel very confident that we could have shrunken that kind of large-ish tumor into something much smaller and either done a cryo, you know, freeze it off, which is, you know, you walk out of there, like there's no like huge recovery time. And they would have gotten, and even if she would have done a regular lumpectomy, I think we could have gotten clean margins because of all the stuff that we know to do. So I agree with, yes, she should have a lumpectomy or maybe cryo ablation. So the recommendation was the same, but the timing, the when was different. So the doctor recommended, yes, do lumpectomy, and I agree, but they didn't say, but do all this stuff Oscar wants you to do for at least a few months, and that way you can shrink it and have a much, you don't have, you know, more likely, can't guarantee anything, but way more likely to get clean margins on a 1 centimeter tumor than a 4 centimeter tumor that's kind of weird shaped and kind of crawling all over the place, right? And I pretty much always see breast tumors shrink, no matter, you know, no matter what we do. There's so many tricks to get these, you know, I can't say I can make them go away, but I can say pretty darn confidently that we always get them smaller, and smaller means smaller surgery, less invasive, faster recovery time, less inflammation, more peace of mind, more LSD, long, slow, deep breathing before, during, and after, maybe before and after at least, the procedures, which means better long-term overall quality of life rather than, you know, more surgeries.
So you mentioned something called a Ki-67. Dr. Levitt, what is that test, and do you use that traditionally in your practice?
Sure, it's one of the tools I was alluding to when we're looking at things on the cellular level. I mean, so when I was talking about the clinical picture of looking at a patient's body versus the cell, obviously that was a little bit simplistic, but that's looking at the on the cellular level, that's looking at like one of the more common core pieces of evidence that we have to look at. And then the body, the effects on the body, or the relationship of the tumor with the body that we can appreciate, is probably one of the furthest downstream tools or things that we could look at to describe it. There are a ton of what I would call indirect things that we can look at to add to that discussion and that picture, because while a lot of types of cancers are similar, there are others that are unique in the way they behave and the way that they act. Still in the same paradigm, where are they fast growing, are they slow growing, but they don't all make Ki-67. They don't all make CAA. They don't all make CA19-9. They don't. So there are categories that these things apply to, and then there's, at least from the science that we know today, which 5 and 10 years from now we'll look back on and say, gosh, that was pretty simplistic thinking. But that's just the way we have to proceed, at least in the Western paradigm of looking at evidence-based medicine, and then all, you know, the different ways we study things, at least historically. So a Ki-67 is a lab value that accompanies what we look at under the microscope. And this gets into a whole field that you can get a PhD in on cell biology or cancer biology or pathology and looking at things either at the cellular level or the genetic level or the mutational level, histologies, just depending upon the tools that we're using to look at them. Some things not dissimilar from the Ki-67 or some of these other markers that Oscar and I both use, albeit in slightly different ways sometimes. Some things can just be checked in the blood. And now a lot of people probably hear about or are learning about these things called liquid biopsies is sort of the catch term that we're using to say, is there something that you can look at in the blood that tells you if you have cancer? Well, there's a lot of products out there. They're all currently vying for pole position in the industry and in the marketplace. But right now, the science is pretty good, but there's a lot of false positives, a lot of false negatives. So they're not one of these things that should be replacing everything we've known beforehand. They're things that are adding to this conversation, like the Ki-67, like these blood markers. But like for men, they usually around 40, but at least by 50, they're getting a blood test to look at the PSA, the prostate specific antigen. The way I think about that is that's the poop that a prostate cell puts out there. A normal prostate cell puts it out there. A bad prostate cell, a cancer, puts it out there. And you can look at the breadcrumb trail that those tumor cells leave in the blood, and you can actually plot it on a graph and determine the slope of, is this going up very slowly or is this going up very quickly? And that's a very objective and quick way to understand, are these cells dividing so quickly or are they making so much PSA in the prostate specific method or not. So without trying to dive deeper into what's termed like basic science or the molecular science of what makes these things, because whatever we learn today, next year we're going to have more information about. It all has to be taken into context. Is this tumor that you can feel in this person's lymph node growing every week you measure it? I mean, we actually this is not all, sci-fi rocket science. We use tape measures and we measure things. And in the operating room, we use drills and hammers and screwdrivers and screws and nails and all of it. It's just you're asleep, so it feels like it's this magic thing. But like Oscar's saying, it's pretty primitive still what we do to our bodies with conventional or modern medicine. You don't fault everybody for it. It's the game that the Western Hemisphere plays, and there's pros and cons to it.
Okay, so I think what I just understood is there are blood markers, sometimes liquid biopsies, or sometimes it's just other blood markers, other ways that you can measure how fast a cell replicates or the cancer activity in your blood. And that's one of the tools I used to identify that I was actually not chemo was not working for me, is I used some of those blood factors so that I could predict that it was actually going up. The cancer burden in my blood was going up versus down. So that's another way that you could measure, hey, listen, is the cancer on the upswing or on the downswing in my body as well? So I love that idea. But one of the questions that I want to make sure we share with our audience is how they can understand themselves if this is one of those things that, yes, I got to move pretty quick, or no, this is something I have some time to think about. So are there any specific questions that our listeners could ask their doctor or should be thinking about, or tests they should be requesting that aren't standard of care or anything like that would help them understand, hey, listen, I've got some time to really think about this, or I got to move fast?
So that scratches the surface of all sorts of other topics, in the sense of like getting to the core of like your relationship with your treating physicians or your care team, and who is that care team, and in what manner are they listening to you? Is it from a textbook point of view, or is it from a if I were in your shoes point of view, or is this from a well, here's the standard, but I'm willing to explore with you what may be more comprehensive and integrative or complementary or progressive or experimental, and everybody's wired differently. So this idea that is sort of unspoken, that the cancer is the thing that's common to all patients, and that the host, the individual, really is just along for the ride, is really missing a big piece of all of this. In that the host, just like ourselves in life on this planet, there's a nature and there's a nurture. And the way that we behave, the way we interact with our society, with our environment, with our peers, with the way we internalize things, the way we express ourselves externally, it has to affect the way that our body deals with disease processes that may be similar, but by no means are ever an exact replica of somebody else in that situation. So I guess to answer your question about how can a patient glean when it's urgent, you have to first sort of scratch the surface on where am I getting my information from, and is the doctor, while they all might be a surgeon, like I might see 4 surgeons, or I might see 4 oncologists, and the textbook says the same thing, but the way each of those oncologists or care providers explains to you when it's urgent, or what you need to do, or how you would approach it, has a whole layer of subconscious as well as conscious bias and anecdotal experience. And at the end of this, a theme to Mojo Health, and a theme that I'm hugely supportive of, is more important than finding the guy that wrote all the textbooks and did all the experiments and graduated at the very top of his class in the best schools with the best pedigree. It's arguably more important to find that person who's going to sit there and listen to you and empathize with you and use their expertise and their skill set to say, if I put myself in your shoes and I try to envision how I would approach this, this is with what I know, this is how I would approach this. And that arguably will take into account other factors that are going on in your life, as well as other factors that might be limiting in like the ability of them to get you into the operating room or get you into a chair, or maybe they do have availability and it just is super convenient. You need someone who's going to explain to you how to reach a decision, not just my way or the highway. And so there are certain things, if you meet one person and 2 people and they're both saying, look, if you don't get this taken care of next week, you're in trouble, and everybody's telling you that and no one's veering from that, well, that's probably worth listening to. But if one person says, look, I've got time in the OR next week, we can take care of this lickety split, let's just go and do it, there's no reason to wait. But you got someone else saying, look, I want you to be comfortable with your decision, because not every procedure, surgical or chemo or radiation or supplements or anything, are safe. So I want you to be as well informed and comfortable about your decision as possible. And I think that's as important as taking care of this in a timely, responsible way. Well, now there's not a consistent urgency with that picture. Now, if you can't breathe and your oxygen levels are dropping, or your plumbing's clogged, or you can't speak because something's pushing on a part of your brain that controls your speech, probably pretty important to fix that before it gets worse. If things have rapidly been changing, you thought about going to the doctor last week, but over the weekend you started to have a whole bunch of pain that just wasn't getting better. And in fact, Monday it got worse, and Tuesday it got even worse, and today you're in the doctor's office and it's almost unbearable. That's telling you a trajectory that you're looking to in the future. If you don't fix something, it's going to break you. And those are the kinds of urgent things. But really the theme of this talk and this topic is that the majority of the time, It's not that situation. The majority of the time, something gave you a heads up, you investigated it a little bit more. Unfortunately, sometimes it results in something scary sounding, but before you rush to do something about it, there's usually a lot of options and education that you deserve and should tell yourself you deserve to make an educated decision about, do I want to do this or that? And, sometimes there's only one option. You treat it or you don't. But usually there's a few different ways to approach that, and that gets even more complicated. So you have to empathize with the human in front of you. And as a patient, you should try to engage the doctors in that type of conversation. Don't just, I'd like to know what the textbook says, but I'd like to know what you would do if you were in my shoes. And I'd like for you to tell me what your best recommendations for me on my next steps to approach a decision to manage this disease process would be. And hopefully with just those types of few simple bullet point questions, the person you're talking to take care of you will reveal to you what type of audience they are for you, what type of care provider they are. Are they just a clinician who delivers treatment, or is there something a bit more that they're trying to take care of really the whole body, and which affects the disease? We just get, like Oscar was saying, we get very myopic, nearsighted, and focusing only on the disease. We lose the face of the patient. Arguably, that's 180 degrees from where we should be.
Reminds me of being at I just thought of this, like, clearly my first love is music and my second love is food, but I imagine being at a restaurant, and like the difference between a good waiter and like a mediocre one and a great waiter is like a mediocre one can just read you the menu. Well, this is the standard of care. You can do this, this, and this. And, and they're like, well, what do you recommend? And someone might say, well, we have a lot of leftovers from yesterday hot dogs, so we want to get rid of those hot dogs. And it's convenience is what they're not saying. What's convenient for us is that you order the hot dogs, because we really need to get rid of those hot dogs, and we have availability for you to order that hot dog next week. We got space in the OR. That's what's most convenient for us. My son needs to go to Yale Ivy League school, and tuition's next month. So that's the urgency is that. Or, you have like a waiter that says, well, what other kind of food do you like? Do you like sweet, or even if it's something really light because you're going to go dancing afterwards, or like you haven't eaten all day and you could really go for something really hearty? Do you tend towards fish, or or something creamy, and then kind of set the menu aside and say, well, what do you create? Let me listen to you and what you want, because this dining experience isn't about what I want as a waiter or what we happen to have extra of because it didn't sell yesterday. This is about you. And, and also, like you said, like there's a difference between urgent and important. It may very well be urgent and important, like your brain all of a sudden doesn't work because something is pressing up against your brain and you have aphasia, you can't swallow, you can't breathe. That's urgent and important and critical. And then most cancers are important but not urgent. And then there's some other things that I would say are associated, would be clots, which could be its own podcast, which are important and urgent and no one pays attention to. And I always say it's everyone's concerned about the T-Rex in Jurassic Park that's 1.5 miles away, right? But in the bushes 20 feet away is a velociraptor that no one thought about. And it's not the T-Rex that's going to take you out. That is, you can see cancer coming miles away. Like, lung cancer and breast cancer and prostate cancer has killed no one, all of a sudden, right? But clots take you out like that because everyone's focused on the cancer and they don't pay attention to the important and urgent velociraptor that's super easy to manage, control, and mitigate risk of if you just check for it. But no one does. So that's, and it's distinguishing between important and urgent and important, and sometimes just not important, like a lot of the BS in people's lives that, the potato chips and alcohol and the keeping up with the Joneses stuff that took up, 30% of their life and attention and awareness, that was neither important nor urgent.
Yeah. I mean, we're extrapolating from like the 7 Habits of Highly Effective People stuff, which you want to keep things out of those urgent and important blocks. You can deal with important but not urgent. You can deal with urgent but not important. You can deal with not urgent, not important. There's very few things in life, hopefully, if you're kind of keeping abreast of things that are urgent and important and need to be addressed quickly. So it's a good mantra to try to keep things out of that category in life by proactively addressing them. I agree. As you were talking, I almost feels like it's good. It's well, you go to McDonald's, you don't have really a waiter, you have a menu, but there's no sommelier. And what you're talking about is you want a sommelier to take care of you and your cancer. And be it wine or be it the breadth of options to tailor to your disease state.
And here we are.
Yeah, we are.
I think it's really important what you guys just both mentioned, and I just want to make sure I bullet point this for our listeners, is you want multiple opinions as well. It is really healthy to not go to one doctor and then say Tuesday and you say cool and you go do it on Tuesday. There are differences of opinions, not only at one health center to another within the same regional area, but across different regional areas, you might get very vastly different opinions. And that's one of the reasons why I'm not sure I would say if the first oncologist, I would have followed them and they would have said 6 months of chemo and then we'll do a PET scan. And I said, okay, I would have had 6 months of toxicity without ever knowing that I was chemo resistant. Instead, I had that oncologist plus Oscar plus 8 other doctors that I listened to and was able to build a care strategy that brought together the very best of all our lessons. So the first thing I want to say is, guys, don't just take the first offer. Sometimes you got to negotiate and understand what really works for you. So gather multiple opinions. The second is flat out ask, is this urgent, to everyone you talk to and get their understanding and what their strategy would be to help. So those are really fair questions to ask anyone you meet with. Oscar, it looked like you had a point to make.
Well, it just reminded me of, to your point of like, get another opinion and how worthwhile is this first opinion? Like yesterday, was it we were at a restaurant and I was wondering about their tacos. So I asked the waiter at a pretty decent restaurant, what do you think about this, this, and this? And she was like, well, people like the cheese dip. I'm like, well, what about these tacos? And she's like, well, I hear they're good. Well, she's a vegetarian. She's never had any of those tacos, right? So like, why would I trust her opinion on those tacos? I could get another waiter and be like, oh, I've had all the tacos, and the tacos al pastor, although they're not on the vertical rotisserie, have this excellent sauce and we do them just right. Oh, great. I trust that guy. But I don't trust the vegetarian to tell me about the tacos al pastor, right? And that's okay. It's not a dig on vegetarians. She should have just kind of been honest right up the bat about like, hey, I can tell you what I've heard. I can tell you what people order, but I can't tell you what anything tastes like because I don't eat most of the stuff here. Yeah. And same as a doctor's like, well, I have no training in astragalus and schizandra and any herbal, or mistletoe or anything like that. So I can't speak to that, but I can tell you about chemo, radiation, surgery because I know that's on my menu every day. Ask someone else about the mistletoe and the herbs and the acupuncture, whatever. That's a fair thing to say, but weirdly, they wager an opinion as a vegetarian on meat that they've never tasted, sadly, and it should just not be done. Just say that you're a vegetarian and that you don't eat tacos al pastor. That's fair.
And yes, absolutely. And I think the value of having multiple opinions, multiple education backgrounds only makes you smarter because you learn different things everywhere you go. But
let me say something about that because it comes up quite frequently, and there's a huge other value to another opinion when time allots for it and when your anxiety and everything allots for it. Sometimes it's not only for you, but it's for your loved ones and your support system, because what people don't think about a lot when they're dealing with things on this side is the future possibilities. Everyone wants, you want to envision positivity, you want to realize wonderful outcomes, but that doesn't always happen. When you've got a disease, when you've got a cancer, there's really only a few scenarios that are going to occur if you get treatment of any sort. You're going to find yourself downstream on the backside, hopefully, of all this with no cancer and no side effects. In which case, we're all happy for you, no matter what the journey you took to get there was. It worked out for you. You're great. You're getting on with life. I think all of us here would love it if you actually at some point looked back like you, Julie, and said, my life's better because of all that. I took that silver lining and thrived because of it. Great. But it doesn't matter what you did. You ended up that way. And that could happen, but it's hard to predict. You could have no cancer and a whole bunch of side effects down the road. And you might look back retrospectively and say, with 2020 hindsight, gosh, maybe I would have been cancer-free without all that toxic treatment. Maybe I did a little bit more than I should have. You might have cancer that comes back or never went away and no side effects. And you might look back and say, gosh, maybe I should have done more aggressive treatment because I didn't have side effects, but I've got cancer, so maybe I should have done more. Or in the worst situation, you've got cancer and you have side effects, and you fought a good fight and it still ended up not where you exactly wanted to. Or maybe not fight. I don't like those battle words when it comes to cancer and living and thriving or healing. But anyways, you went through it and it still didn't work out the way you wanted to. Now, on top of any of those future potential paradigms, you're going to look back and reflect upon what you did do, what you didn't do, what you knew about, what you didn't know about, what you now know about. I wish I knew now what I didn't know, all that. And a second opinion in the future may give you some peace and comfort, or your support system or your loved ones, that you did all your diligence and you did the best you could do with the information and the resources you had at your availability then. And the future turned out the way it turned out because of life and things that we can't objectify. But that second opinion on the front side might give you, and often does, vastly more comfort and peace where you find yourself in the future in pretty much every situation, other than I have no cancer, I have no side effects, so I'm not looking back anymore at all. Like it didn't matter. But every other scenario, that second opinion or third opinion or extra time or extra education or extra consideration or extra advocates or consultants that you had lets you feel confident that you didn't take the shortcut, you didn't contribute negatively necessarily to your future, at least in the way that and that you took this as seriously as you should take anything, or as one would like to think they would take anything. But the reality is a lot of people make these treatment decisions with far less diligence, far less information, far less questioning than they do when they go to buy a pair of sneakers or a new TV or game system. And it's based upon what we started out talking about, not the individuals necessarily in a conscious way, but the landscape takes advantage of the reflexive decision-making capacity that's induced by fear, by culture, by anxiety, by that loss of a sense of control, when in reality we had no control over most of any of it to begin with.
Deep thoughts by Dr. Chad Levitt right there, guys. That's really important to understand and think about. And I think just to kind of share for those of you to reflect on my story, I did stop and take some extra time. I met with Oscar. I built my body up. The way he explained how I could use that time is by getting my diet, my exercise, my sleep, my mental health, all in the best case I possibly could. He added supplements by doing blood tests so that I knew I had needed more magnesium and vitamin D and all the things so I could build my body up, because it's going to take a hit no matter what you do, whether it's surgery or radiation or chemotherapy. It does not matter. Your body's going to take a hit. And when you go on an 8 and you take a hit to a 6, you kind of ride the wave and it's no big deal. But when you go in at a 4 and you go to a 2, you're miserable and you're bedridden. So that time, the reason why understanding urgency is so important is because you can help heal and prepare your body. Just like a marathon runner does before a marathon, you can do that before treatment. So this time is your gift to help you heal whatever you can and strengthen whatever you can so that you don't feel that impact. And with that time, I was able to take the magnesium and the quercetin and all the things that Oscar prescribed, and I didn't really have side effects. And I had a cancer experience that most people couldn't dream of. I did lots of things to prevent for that. From everything from I had cold sensitivity as a result of oxaliplatin, and I ate ice chips and had ice bottles on my fingers and hands, and I didn't have any sort of cold sensitivity. You can do capping, which prevents you from hair loss. You can do vitamins and minerals and botanicals and nutraceuticals that'll help you not have neuropathy. There's all sorts of things you can do to prepare your body. So this question around urgency is important because it allows you to prepare the playing field so that you can have the game of your life versus play a crappy game. So I just wanted to make sure you understood that. Oscar, I know you taught me a couple other things early on this meaning of time. What else do you do if traditionally someone comes to you with a little bit of time, you can work with their body?
Becoming a data G. So looking at the long game, like, okay, so suppose you're going to do the conventional, standard of care, the chemo radiation surgery. Okay, well, at least let's get some data, be a data G, and get the tumor markers, get the serum HER2/neu, get a Signatera. And then we can to assess, like you said, if it's going to fail, I want it to fail quickly so that we can pivot and do something different. Even if you're not going to do anything natural or vitamins or minerals or yoga, meditation, or jumping up and down, you're just going to do standard of care. Fine, at least measure to see if the standard of care is working or not. That's fair, right? Measure to see if the dinner that you're eating, is rancid a couple bites in rather than after you finish it and you have diarrhea for the next 3 days. So, are there ways to measure efficacy early on and also for a year or 3 or 4 down the road, besides waiting for the clean MRI or CT scan, are there other things that can let us know early if there's a recurrence? Yes, there are, like tumor markers and the CT DNA and the Signatera's and, thermographies, I would add. So is there one thing that you can hang your hat on? No. But, if you have a thermography and a tumor marker and a Signatera and a high neutrophil lymphocyte ratio, that's pretty solid evidence to convict on. So if you had that before you did before you did the standard of care or the prayer and jumping up and down and meditation with a piece of astragalus in your ear the whole time or whatever you want to do, that's probably an indication that a year or 3 down the line, if those same tumor markers, the Signatera or the high neutrophil lymphocyte ratio all coincide again, looking kind of like what they did 3 years ago. Guess what? You probably got a recurrence and you'd rather know early than wait for it to be how many billions of cells, Dr. Levitt, before it shows up on a scan?
Yeah, probably at least 500 million. By something's 5 millimeters, which is usually a pretty repeatable measurement for sensitivity from an MRI or a PET scan. You're going to have 500 million cells. By the time it's a centimeter, which is hard to ignore, that's going to be 1 billion cells.
So I'd rather know when it's a third of a centimeter, which would show up on these more sensitive things, but only if you had something to compare them to, which is my point. So, this is not urgent. Your brain isn't going to explode or an alien's not going to pop out of your abdomen the next week. Get the data so that you compare it a year or 5 down the road to give you the peace of mind then. At least.
Let me clarify something so that patients don't take what we're saying out of context and possibly find themselves, having people roll their eyes and things at them. Exactly what you just said is so critical. We're not saying that there are a whole bunch of other tests that every doctor just needs to be ordering to help take the best care of you. Like, meaning, oh, if they didn't order a Signatera or a Guardant or circulating tumor cells or something, that they didn't do their job. They might order it and it still isn't of value unless it's taken in context, like you mentioned, compared to other values. It is almost, it's there's almost never a situation right now about these topics where there's a simple test. Imaging is something. If you see something, there's often something there. You can prove it, you cannot. But most of these other things that we're talking about are not snapshots. They are tools to help know where you might be in your journey if you have a baseline, or if you have a point in time in which to compare it to. And that's not something that most individual doctors, be it integrative, naturopathic, conventional, Western, whatever, are equipped in a comprehensive manner to guide most patients through in all situations. This is where a team of like-minded people openly discussing all the information available for you, for your care, can come together to kind of create that roadmap and understand where you are in a situation. But if you're, let's say you're 3 years in to your breast cancer journey, you've been treated, there's no other traditional evidence of cancer, and someone orders a Signatera that has a value that's sort of like on the fence, there's not a lot you can glean from that, usually, unless it's alarming or outside of all potential norms. When we use the words specificity and sensitivity, while a lot of us have an idea what those terms mean, they do have very specific, they do have very unique and universally accepted definitions when we're talking about statistics or Western medicine statistics, when we're talking about tests. And a lot of these things that we're talking about right now as being additional to the core base standards, don't have in and of them, their individual testing selves, the highest specificity and the highest sensitivity, meaning that if this test shows this, it means this 100% of the time in every patient. Or if it doesn't show this, it means that you don't have this. It has to be taken into context, both temporally from one time period to another, as well as individually. So you can only compare yourself to yourself when you're going through these journeys, because it is an individual and unique journey. And you need a team of people who are willing to say, how does this fit into the context of everything else that we're doing? So I just want to say that so that patients don't hear some of this or some of what Mojo Health and we talk about in other topics or other forums, and go to their traditional doctor who isn't used to having this conversation and say, I need you to order this test because I don't think you're doing your job. Like, that alone is going to get them cared for in a slightly different way than what they normally do, and than what they would normally like. And so it really, everything needs to be taken into context against itself. And that message will be much better digested by your traditional treatment team, as opposed to maybe making them feel marginalized by saying, you just don't understand what you're talking about.
For sure. So, guys, I know our listeners are probably ready to wrap this up. So I just want to say, I do want to make sure we've been talking so much about cancer not being urgent, but there are a few cancers that are, in fact, things that you need to move pretty quickly on. So I want to make sure that we take 5 seconds to just say, here's when you do need to move quickly. And if you need to move quickly and you have a very short amount of time, this is what we would suggest you do. So I just wanted to say, Dr. Levitt, and then Oscar, if you'll share as well, when would you say, okay, this does need to move fast? And if you can only do one thing, this is the one thing, or this is the 2 things you should do very fast.
So it's kind of like, I mean, that's that's what most of the doctors' voice messages at their office will say to you when you call after hours and there's not someone immediately there to take the phone call. If you are fearing for your life, if you are having trouble with your basic functions, breathing, speaking, seeing, pain tolerance, weakness, I mean, if there's something that makes you unable or almost unable to take care of yourself in the basic manner, you should get to a doctor, if not an emergency room, quickly. And, you know, that's without going into the guttural thing that some patients just know there's something that's not right and I need it to get addressed urgently. That's a little bit different. But if you look at your basic vital signs and you're having trouble breathing, you're having trouble eating, pooping, drinking, speaking, walking, sleeping, not just bothersome, but this is like ongoing and even more important, worsening. Those are things not to ignore. They need to be addressed because, to be honest, common things are common, and cancer is not the most common thing. A blood clot, a heart attack, a stroke, all of these things could be going on. And maybe in some situations you do have cancer that brings these things to your attention. So in an indirect way, the cancer can help you. But the more urgent things that are life-threatening are often not cancer related. They're often either indirectly or coincidentally occurring.
Yeah.
Yeah. Ditto.
And I
And
would
they're
just,
related. Like the clot thing is related, and the mechanical impact on a tube, be it an airway tube or a pooping tube or a bile tube, is related, and because the tumor is pressing up against something, but it's not. Like you can put a stent in, you can just kind of shave that part off, a little spot radiation. It's not really treating the cancer, it's just treating that one symptom, which will massively improve quality of life. And that's totally important and urgent to do. And I would still argue, like, while you're at the hospital, like, it's not that hard to run a CRP, It's not that hard to take some Inflamaway supplements, while you're at the hospital to bring your inflammation down. It's not that hard, like I've had some breast cancer patients that were bleeding, but like, come on, they were bleeding for months and months. It wasn't like all of a sudden an alien popped out of the breast and bled out. Like, no, that's a gunshot, you know? So it's rare, it happens, and like Dr. Levitt said, you probably had some signs and symptoms before that either you were in denial and your head was in the sand, or you're just a really out of touch with your body male.
and I would say for me as the patient, I did end up having to have emergency surgery because my colon did close and I couldn't eat or process or poop. So I ended up having to have an emergency right hemicolectomy. Besides that, Mike, I had plenty of time to think and prepare my body. But my greatest regret is that I don't have baseline data. I didn't get all the blood markers I wish I'd gotten before surgery so that I would have this. I have it all the week after surgery, so I have it then. But if I had one thing to tell you, and you did have an urgent surgery, it would be to identify within an hour or two all the data you could get that could end up being your baseline data that can help you later in life to understand recurrence or understand the score on your cancer burden. So that would be my one piece of advice to you from a patient perspective of be a data G. Get as much information as you can before you do anything, regardless of if that's praying, regardless of if that's surgery, regardless of if that's radiation. Get your data, do the intervention, get your data. That's the whole point of the scientific methodology of gathering data multiple times to show change over time. So that would be my piece of advice is be a data G, collect your data. If you have an hour to collect your data, if you have a month to collect your data, if you have 6 months to collect your data, gather the data. That's the one thing I would think I want to make sure you leave this podcast understanding how important that piece is, regardless of urgency. All right, gentlemen, I know we got to wrap up. Anything else that you would share with our listeners?
No, I think that data G message is great. I phrase that a bit in the sense that don't burn any bridges. Once you jump to treatment, once you destroy that tumor, you destroyed a lot of information. And if it's not a rush, because of everything we're talking about, gather that information before you drop the nuclear bomb on the tumor so that down the road you have peace and confidence in your surveillance and your survivorship and your thriving, so that you know and can use all of the next generation of tools and collage of available resources that we have now, and we're going to have more in the future. But if you took that tumor out and put it in the trash can reflexively, emotionally, urgently, at the beginning without collecting that baseline information, you burn some bridges. And that's kind of what we're talking about. I think I better understand our mantra of be a data G in that context.
Yeah.
Yeah, and I'm maybe not as forgiving as Dr. Levitt is, and I maybe a little bit disagree with him in this context. Like if they can, in an actual emergency setting, a heart attack. Okay, this study was actually done where they took an additional CT scan on someone's face to check for dental root canal and dental infections, which is not a medical emergency, but even they got approval to do on humans in an actual medical emergency of a heart attack that kills millions of people, every couple of days. They still had time to run a CT and collect a little sample of the infected tooth while they were still doing the clear and the stents and the bypasses and all that stuff. They had enough time to run a freaking CT during, not instead of, but during all their normal treatment. And they found out the causal, not connection, causal between root canals and heart attacks, because they bothered then cross-referencing the bacteria that was at the root, and the plaque that was in the artery that was clogged up was the same exact DNA. It's the same bacteria. So smoking gun. So if in an actual medical emergency, they have the time to get some data like that, they, in your case, which was super uncomfortable, Julie, like you were bloated and you were stuck, your plumbing was clogged, right? But that was urgent, yes. But if you waited an hour to do the surgery instead of, like they could have run the tumor markers. There's no excuse. I'm sorry. I don't think they have an excuse. I do think it's negligent. I think it's negligent. I'm just going to say it. I think it's negligent that they didn't run the tumor markers, because what does it cost you? How much was that test, Julie? Tell us how much that test was.
$30.
$30. Okay. $30. And how long does it take to draw blood, Dr. Levitt?
No time.
A couple minutes. Okay. So a couple minutes and $30. And they couldn't bother being thorough to run a $30 test and take 5 minutes to run some basic blood work. I'm sorry. I'm just going to say, you can edit it out if you want to later, but I think it's negligent.
Well, regardless of what you say, it is not in your best interest. Regardless of how we classify this from a doctor's perspective, it is in your best interest to have baseline data. It is in your best interest to gather data multiple times throughout your cancer journey to understand what the score is, what you need to do to be personally responsible for your health, and what you need to do to advocate for yourself. So we're going to wrap this up by saying, be a data G. Understand, is this urgent? Do you have time? Can you prepare yourself like a marathon runner? What are your options? Do you have the right team in place? Those are all the decisions that you need to be making right now. But the very first question is, do I have time to make this decision? And so I would start to collect that data, being the very first thing you start to wonder about. I hope that this episode has dropped some knowledge bombs to allow you to dig a little deeper into what you need to understand in order to really create a beautiful health journey, but also to help you breathe deeper, take some LSD or some long, slow, deep breaths, and make sure that you aren't creating more chaos in your body with the stress you're providing by thinking, I have to do this right now. You don't. You have to get the data. You have to make good decisions. You have to make decisions that'll help you long-term, not short-term. So we hope that this episode has dropped enough knowledge bombs on you to allow you to navigate your cancer journey differently. I couldn't be more grateful for Dr. Levitt and Oscar for joining me. I just adore both of you, and I know our listeners do as well, and appreciate your candor and honesty So thank you for joining us and sharing your knowledge with our listeners as well. So may everyone live long and lucky. We're so grateful for you. Take care.